Welcome to today's webinar with the Accountable Learning Collaborative, excuse me. This is Tom Merrill, and I'll be moderating today's webinar. The payment debate: is capitation the ultimate accountable payment model? We're excited about today's presentation, the opportunity to hear from Dr. Brent James, the Chief Quality Officer at Intermountain Healthcare, and he has recently stepped down, we should clarify, but are very excited nonetheless to have him with us. As you saw in the webinar invite, we'll be discussing Dr. Brent James' views on payment reform. Despite near unanimity in the belief that current payment models need to change to allow organizations the freedom and the accountability to provide the best care possible, the debate continues as to which model will be most effective in achieving that goal. Today we'll discuss Dr. James' position that in this debate between capitation and other payment models, the conclusion is clear. Capitation is the goal, and Intermountain has the results to justify that conclusion. So just a few housekeeping items before we get started. We will be reviewing slides, so if you're able to join the Zoom webinar on your computer, please do. If you're only able to connect by phone, don't worry. We'll send out the slide deck after the call along with a recording. There will be opportunities for questions in the last 15 minutes, so please submit them using the question module in the Zoom application. And as a new note, we'd like to give added context to your great questions by letting the presenter know your name and organization. So if you'd rather not distract us with your fame or institution, just submit your question as anonymous. Otherwise, we'll indicate where the question came from. So we'll plan to cover a few things today. First, so let me go to the agenda. We'll do a few ACLC updates. I will introduce our guest presenter, and then obviously we'll have by speaker.
No, I can hear you again, Tom.
You can hear me again? Okay. Those who are on, can someone send a chat? Now we can hear you. Okay. Oh, it's quite a delay. All right, we apologize, folks, for the technical difficulties. Okay. All right. Okay, so let's go over the upcoming member events. We 11th. Look for details in the news. We do have September work calls coming up as well. In those invites, reach out to Jan or Chipping if you have any questions. So, and then just one last reminder that the ACLC member only event. I'm getting a note that we're not seeing the slides. So that's Dr. James's computer. Oh, let's see. Sharing the screen. Okay, apologies everyone, we have to this degree. All right, you should be seeing my screen momentarily. Should be seeing, to remind you of, was the member event in DC on October 4th, which is shaping up to be a really, really good event, and we hope to see you there. So please make sure to get there. So let me introduce Dr. James. So Dr. Brent James, as mentioned before, recently stepped down as the Executive Director of the Institute for Healthcare Delivery Research and Vice President, Medical Research and Continuing Medical Education. For more than 30 years, Dr. Brent James has championed the standardization of clinical care through data collection and analysis on a wide variety of treatment protocols and complex care processes. Dr. James has devoted himself to using quality improvement tools to better understand the cause and effect relationship between various practice and environmental factors. Today, nearly 100 years after his mentor's groundbreaking discoveries, Dr. James firmly believes that the practice of medicine and delivery of healthcare stands at another critical crossroads. So at this time, we will turn it over to Dr. James. Welcome.
Thank you very much, Tom. It's a delight to be with you this morning. Oh, it has been 31 years. Excuse me. I left the Dana-Farber Cancer Institute in Boston in 1986 to come back to the mountains in Utah. I was a trained clinical researcher and pretty good at it, I think. Really with the largest multi-center clinical trials group in the world, Eastern Cooperative Oncology Group. I was over GI tumors. At any given point in time, I had about 5 or 6 randomized controlled trials running. I arrived in Intermountain, and I was shocked to discover a few months later I was the 3rd physician in Intermountain's administrative hierarchy. Frankly, part of this time I didn't know that administration existed. Big changes for all of us. What we really did, though, was to take the tools of clinical research, some very sophisticated measurement and analysis tools from clinical research, well-established methods, and shift that magnifying glass to focus on care delivery performance. Prior to this time, everybody just believed that if you were a highly trained physician, duly certified, board certified, recognized by your professional society, it was quality care because I did it, by definition. When we shifted that over, though, we got the surprise of our life. Now, if you were to do a Medline search right now, looking for articles in the peer-reviewed medical literature documenting various aspects of variation in clinical care delivery, you'll roll out well over 40,000 articles, amazingly consistent in findings across about the last 50 years. Well, yeah, I've broken that variation literature here into 5 major subcategories. I actually used this when presenting to the Senate Finance Committee back in the run-up to the ACA. Number 1, massive variation in clinical practice. Really, the champion for this work was Dr. Jack Wenberg at Dartmouth, of Dartmouth Atlas fame. He published his seminal article in the journal Science in 1973. Jack's point, the variation is so large from one practice to another that it's pretty much physically impossible that all patients, even with full access to care, could be getting good care. While some looked at the variation literature, geographic variation, came up with a hypothesis. They said perhaps we can explain geographic variation by what they called inappropriate care. Now, they used a completely medical model. Care was judged inappropriate if the risk inherent in the treatment outweighed any potential benefit. This among clinicians who held as their primary maxim, first do no harm. These are the areas where we put patients actively in harm's way. 2 major findings from that branch of research, that series of studies. Number 1, it turns out that inappropriate care does not explain geographic variation. On average, communities that had low use rates for a particular treatment had about the same proportion of care judged clinically inappropriate on careful review by one's peers as did a high utilization community. A secondary finding, though, that was much more troubling. Well, the high watermark in that first series of studies, carotid endarterectomy, 32% of all cases performed judged to be clinically inappropriate. The risk to the patient outweighed any potential benefit. It should never have been undertaken, but it was anyway. If you think number 1 was deeply troubling, number 2 completely overshadowed. Deeply, deeply troubling. By the way, since then, we've had other trials that suggest the rates could be even higher. Stenting rates, the COURAGE trial in cardiovascular medicine suggests that stenting rates 50% inappropriate, very controversial, as you might expect. Number 3 on the list, November 30th, 1999, Institute of Medicine's Committee on Quality of Healthcare in America publishes a report called To Err is Human. You're probably familiar with it. That's where we estimated somewhere between 44,000 and 98,000 preventable deaths per year in hospitals in the United States, where the cause of death was not the patient's underlying disease, but the treatments used to address those diseases in a way that 2 independent physician reviewers separately agreed were avoidable. Now, Truth in Advertising, I was a member of that committee. We've done a full evidence review. We found about 60 major articles documenting this unfortunate fact. Believe it or not, we were trying to be conservative. Subsequent studies and treatment tool bumped the injury rate from about 2 to 4% of all hospitalized patients suffering a care-associated injury to 26%. In an article that we published in the Journal of Health Affairs, the associated preventable death rate is about 200,000 preventable deaths per year in that study. Now, in truth, you have to remember that care delivery on average routinely achieves miracles. We add 3.5 to 7 years of life expectancy to every member of U.S. society. Not uniformly applied. For some, it's decades of life, others need much less. But the upside is dramatically larger than the downside. I mean, that upside at 3.5 to 7 years is net of the mortality rate. The crazy thing is most people didn't read the second half of the report, so far as I can tell. The real point we were trying to make is we had established science by which you could dramatically drop the death rate by 60, 70, 80% and still achieve all of the benefit. That was the point. Number 4 on the list, it's really a twist on patient safety. Number 3 we called injuries of commission, where the care actively harmed. Number 4 are injuries of omission. That's where I have hard evidence of benefit, strong randomized controlled trial evidence showing that a particular treatment would benefit people if properly applied. Beth Mulviner-Rance, the person who really did the work, she found that we managed to execute correctly 55% of the time for adults, only 46% of the time for children. Now, this is where I have something I know works, we tend to be non-controversial, we all agree it should happen. Another word for it is reliability. How often can we reliably execute against things that we know work? Think of it this way. It's pretty easy to demonstrate that we do routinely achieve miracles for the patients who seek our help. If we can achieve miracles doing it correctly roughly half the time, what kind of miracles could we achieve if we did it correctly all the time? We're leaving a lot of lives, pain and suffering and function on the table, is the idea. Now, if you take the top 4 and summarize them together, it turns out to be huge amounts of waste in the system. In fact, back in 2010, the Institute of Medicine sponsored a group of experts to come together and review literature around waste in healthcare. Short version, we concluded that a minimum of 35% and probably over 50% of all monies expended in care delivery are technically waste, or associated waste. Truth in Advertising, I'm part of that debate. I add some extra factors when I look at it. The numbers I get are closer to 70%. Well, just take the midpoint, 50% waste. This year, the United States will spend $3.4 trillion with a T dollars on healthcare delivery. What I'm suggesting is $1 to $1.7 trillion of recoverable waste. Think of that for a minute. I sometimes deal with the venture capital market with innovations in healthcare. If they find something that can make $1 billion, they're ecstatic. Huge opportunity. $1 billion market capitalization rate and upside. We're talking here 1,700 billion on the waste side. It's not just that it's huge, it goes a step beyond. It takes investment to eliminate waste, well, but it also takes investment to generate new revenues. Traditionally, the way that people have thought about generating additional margin in care delivery is through revenue enhancement. Add that new service, increase your imaging, expand your lab, build the new heart hospital, buy that proton beam accelerator, you see. Here's the trick, if you make that investment and you do well, a well-performing new service, about 5 to 9% of the revenues you generate will find their way to your operating margin when you live or die. Take a look at the other side, though. A second way that you could actually improve your operating margins is waste elimination. For the same investment, it turns out about 50 to 100%, depends upon specific mechanisms underneath, find their way back to your operating margins. It's not just that the waste opportunity is dramatic. than traditional revenue enhancement strategies. It's also that your financial leverage is much, much higher. About 10 times higher leverage on your investment if you go after the waste side as opposed to going after the revenue enhancement side. The real argument I'm trying to make, in today's market, at least for the next 10 or 15 years, groups that focus on waste elimination and care delivery are likely to do much, much better than those that focus on traditional revenue enhancement in terms of how they think about their business. Oh, wait a minute. It's almost as if I'm describing the foundation for an ACO model, isn't it? Now, the next thing you need to know, in addressing waste, we found proven solutions. The old original experience came way back in 1991. It happened to be here in Salt Lake City. A man named Alan Morris got a big NIH-funded grant to conduct a randomized controlled trial. It had to do with something called acute respiratory distress syndrome, a very, very serious illness managed by a ventilator in an ICU. I won't go into the details of the medicine. The key is in designing the trial, it's that same variation thing we were just talking about. To that point in time, everybody just assumed that patients treated in a top-end academic medical center would, by definition, get good care. Okay. Should I keep going or wait?
Maybe hold off for a second. We kept getting comments that the sound was just not good. So that's why we had you switch mics to see. It was just not our day with technology. So sorry.
Attendees can now hear you speak. This meeting is being recorded.
Reconnecting now.
So hopefully this will solve our sound problems. I hope the people on the phone can hear clearly. We were talking about 1991 and Dr. Alan Morris. Had to do with a solution that emerged mostly by happy chance. Dr. Morris had a big NIH-funded randomized controlled trial. It had to do with a disease called acute respiratory distress syndrome. Technically, we were testing a new intervention. It was an artificial lung. We were comparing it to traditional ventilator management for these patients. For the first time, we thought, though, to investigate did academic this one manages. Turns out they didn't. We found similar variation in that setting as we had in others. You see, to this point in time, we just assumed that academic intensivists would be very similar in their approaches. It was all high-quality care after all. That variation was a death knell for a trial. It's a key principle of trial design. If you don't deliver the care in a consistent fashion, you cannot causally link treatment to outcome. This is why we use protocols in the arms of trials. Well, we knew what we needed. We needed a protocol to manage ventilator settings in the arms of that trial, particularly around ventilator management. Well, we implemented it in a particular way using something called lean principles. Now, you need to understand when you're developing a protocol, you really face some very significant challenges. First, when you're trying to build an evidence-based best practice guideline, we have evidence for best practice only about 15 to 25% of the time on average. 85% of the time, 75, 85% of the time, physicians and nurses can hold legitimate differences of opinion about what's best because there's literally no evidence. Now, it's not uniform, as you might expect. In some areas, it's much higher. I think, for example, in pediatric oncology, because of how we structure the care, probably closer to 50%. On the other hand, general pediatrics, really close to zero. General surgery, where I used to work, really close to zero. Ophthalmology, close to zero. If anybody's ever tried this, though, developing an evidence-based best practice guideline, you'll live this. On average, you'll be able to find about 15 to 25% of what you need. Well, if you don't have evidence, we have a fallback. Generate your own evidence. It's called level 3 evidence. It's expert consensus opinion. You call together some of the more respected authorities and you ask them what the best care expert consensus. This is really the work of David Eddy at Stanford when he was developing evidence-based medicine. David Eddy's the father of evidence-based medicine. He demonstrated that expert consensus is inherently unreliable. What you get depends on who you ask, even at a group level. Ask different individuals, ask different specialties, you can get radically different guidelines. A third major finding that came out of those those studies. It turns out that if you generate the guideline anyway, the traditional way that we deploy a guideline is we train the clinicians. We publish the article, they read it, we have grand rounds, we go through it together, we train them. What you're doing is you're taking the new knowledge, you're loading it into the expert mind, and then expecting those minds to apply it consistently to each patient. Well, here's what you need to know from that piece of the literature. If you go through that training exercise and ask the clinicians if it was valuable, most of them will say that it was. They'll be quite positive. It was a valuable professional experience. If you ask them if they've changed their practice, they will assure you that they have. The wheels come off when you actually measure whether they changed their practice. And a long series of studies showed no change in practice when doing this. The last thing on this list is perhaps most important. I can make a compelling scientific case that no two patients are ever exactly the same. We all differ. We differ anatomically, physically. We differ in circulating enzymes, underlying genetics. We have different exposure histories in our life to elements in the environment. That means different responses to pathogens. It means different responses to treatment. The point, no two patients are ever exactly the same. Every practicing clinician understands this innately, inherently, based upon long experience. It changes how you approach the problem. Well, the approach that worked in the context of that big trial, today we call them shared baselines. The IHI in Boston tend to call them bundles. Some people call them evidence-based best practice guidelines because for me, they evolve from the arms of randomized controlled trials. I tend to call them protocols. Here's the basic idea behind how you build one. Number one, you identify a high priority clinical process. Patients really come to us with a problem, and those processes are designed around the problems that they experience. Type 2 diabetes mellitus. Maybe it's not really a health problem. Maybe it's pregnancy, labor, and delivery. For example, it's one of the larger processes that most health systems execute. A management of ischemic heart disease. You get the idea. Patient-centered care means that we build the care around the patient, around the problems that they bring to us. So you identify a high priority clinical process. Next step, you build an evidence-based best practice protocol around that particular process. I've just described the challenges that you'll face. By definition, that protocol is always imperfect. Poor evidence for most practices, unreliable consensus. We'll build it anyway because of what's going to happen next. Step 3, blend the guideline into clinical workflow so that it doesn't rely on human memory. We know that if you rely on human memory, even really smart, highly trained, deeply dedicated, well-rested clinical professionals, we know that practice doesn't change. You want to make it so that the best care is the default option. Leave it alone, doctor, don't touch it. Call it in, be absolutely lazy. What happens on full automatic is evidence-based best care. This is probably the hardest step in this whole process. Oh, there's a sub-theme with it. Thou shalt not destroy clinical productivity. At least in the systems where I've worked, we've used a series of tools. They always start on paper and eventually merge into the electronic medical record. Well, the most common is a standing order set, something we call a clinical flow sheet, action lists, patient worksheets. We have about 20 little tools by which you blend this into clinical workflow. Basic idea, leave it alone, full automatic. You're going to get evidence-based best care. Build it in.
Yeah.
The baseline. Number 4, in parallel with the clinical workflow, also built into the workflow, build a data system. The data system is going to track 2 classes of data. Number 1, you need to know anytime a clinician varies from protocol. That protocol we build in step 3, vary from it, we need to know. Oh, change an order on the order set. That's a variance. The clinical flow sheet says next we should go there and do that. And you say, nope, not today. I'm going to go over there instead and do that other thing. That's a variance. See the idea? You need to flag every variance and the nature of the variance as it occurs. Side by side with that, you need to know what happened to the patient. Long and short-term patient results, technically, intermediate and final clinical and cost outcomes. You can build it right into the workflow. It tends to be the sorts of information that your clinical teams must have to do their job. It's going to drive a large registry around a specific disease that gives you the data, the evidence really, about our practice and what it produces. in the context of the variation that occurs. Step 5 on the list is the most interesting. I've got strong evidence that with some rare exceptions, there are exceptions, but they're quite rare, you can't write a protocol that perfectly fits any patient. And doctor, that's why we have you. It's not just that we allow or even that we encourage, we demand that you vary based on individual patient need. I need a thinking mind at the interface, you see. Of course, when you vary, we're going to pick up the fact that you're varied. Hopefully you'll list a reason why. We'll prompt you for that. By the way, that's a wonderful malpractice defense. This whole system reduces malpractice rates, I should say in passing. But the whole idea is I have a thinking mind at the interface that varies based on individual patient differences. What you're trying to do is eliminate most differences arising from differences in professional opinion while retaining differences that legitimately arise for patients. And finally, number 6, well, technically it's called a lean learning loop. What you do is feed the data back to the clinical team. If your experience is similar to mine, you're going to see, especially initially when you first introduce a protocol, rather vigorous, frequent changes to the protocol. You'll find that there's a difference between theory and reality. What you produce in a conference room with a bunch of experts around a table about best practice is going to be really different from what evolves when you actually try it at the bedside in the clinic visit as you deal with real patients. So these protocols have to be able to adapt over time and change over time. Of course, you've got a parallel data stream that's telling you what happens. So they're validated. The protocols are validating. And I can now produce real transparency at the front line so my clinicians and the patients they serve can see the connections between the choices they make and the results that they get. This is called a transparent care delivery environment. That's the whole aim. Now, you need to know that this is a very, very robust form of lean. Lean on steroids, kind of. The trick, you can translate it completely into the language of medicine. I tend to do it that way. I argue that it's easier when you speak the language of the natives. So rather than trying to teach physicians to speak Japanese engineering, I just taught the same foundations of clinical medicine that has worked so well for us for the last 4,000 years. And I recommend that to you very highly. Now, when we first did that, in the context of that big randomized control trial, we were tracking the most seriously ill patients. They're called ECMO entry criteria patients with acute respiratory distress syndrome. They had less than a 10% survival rate. With the application of a shared baseline, we 1%, a dramatic change in clinical outcomes. In fact, the first time since ARDS was defined as a syndrome in the 60s that anyone had shown an improvement in clinical outcomes, and it was profound. We knew that we had a live one. We knew that we had something that would really make a difference. Just in passing, by that point, we expected our cost of operations to fall. Nearly always when you reduce variation, you also eliminate waste. We saw about a 25% fall in the actual cost of treating these cases from about $160,000 a case back in 1991 to only $120,000 per case. Interestingly, physician time to deliver the care fell too. It's because you didn't have to bird dog every little step. You kind of automated the scout work and took your most important resource, a trained expert mind, and allowed it to focus where it had maximum impact. Well, lesson number 1 from this whole thing, we count our successes in lives. I have more than 100 of these running in the systems where I've worked that I've been able to personally observe, measure, watch as they developed. The first thing that you learn is that they all show a very high rate of change when you first introduce them and you validate them to reality. That's a very common finding. That change never completely goes away, by the way. It continues forever. I mean, 1991, I guess we're now 30 years on, pretty close to that original trial. The ARDS protocol continues to evolve. Quality improvement projects, new science, it's how you track to current best practice over time embedded into your organization. The big one though, I can document more than 2,000 lives per year in the Intermountain system of people that a few years ago would have died, who don't today, by application of this approach. You understand too that mortality is kind of the tip of the iceberg, dramatically bigger impact in terms of function restored, suffering averted. As a health professional, this is perhaps the most important finding. we could be dramatically better for our patients in their hour of need if we were willing to come together as professionals, share our learning, share our approach in a shared environment, and really focus on patient-centered care. Lesson 2, there's really nothing new here. I argued that when I was in surgical residency back in the 70s, I was basically taught the technique. Now, we didn't put fancy names on it. Lean claimed to have invented this idea of mass customization, but in fact, I was doing it in my surgical practice at least 30 years earlier, before this ever happened, you see. If there is something new here, it might be only this one idea. I did it my way, but every other surgeon on that service had their own personal approach, and we expected the patients and the support staff to adapt to us individually. Well, what if in a shared environment, we had a common shared baseline approach in that shared environment, making it possible for our support staff to actually have some hope of supporting us adequately? It's really a redefinition of a team. Today, almost all care is delivered by a clinical team. Well, what if that team across a shared work environment was able to work from the same sheet of music, from the same basic approach? That's the only new idea here. The method itself, mass customization, has existed within medicine for at least 40 years. Yeah, it should have started in medicine. Well, in fact, it did start in medicine. And now that we've put a formal name on it, we're kind of going back to our roots, applying them more systematically and showing on a very broad spread dramatically better patient results. Another example that I thought you might find interesting, technically, it's a level 3 accountable medical home. We call it team-based care. We published this last year in JAMA. A level 1 accountable home, that's where you do chronic disease management. So we deployed shared baseline protocols around type 2 diabetes mellitus and hypertension and heart failure. Oh, the big one, depression, coming up next at level 2. We had the registry-based tools. We deployed care management nurses into primary care practices. We actually ran a series of trials and demonstrated better clinical outcomes and fairly substantial cost reductions, far in excess of our expenses. Level 2, Brenda Reese-Brennan added in what we called mental health integration. It turns out one of our biggest chronic diseases was depression. We picked up not just depression, but other, mental health issues that could be treated in a primary care setting. Ran another series of trials demonstrating that the embedded psychologists that we had to put in place, the improved data systems, fully justified in terms of pure cost data. It eliminated waste, you see. Level 3, we started to add social workers, a little bit of geriatrics and palliative medicine as well. It was really to coordinate care in the community with care in our clinics and hospitals. So care coordinators that took advantage of other community resources. That's what we call team-based care. We deployed it in a big trial involving about 200,000 patients. Now, this is just the cost side. When we deployed team-based care, we watched emergency department visits drop by 11%, hospital admits drop by 22%, other avoidable visits and admission dropped by 21%. Not too surprisingly, primary care physician visits went up a tick. You kind of hope that would happen. Urgent care visits, that's the alternative to emergency visits. That's our 24/7 walk-in primary care. Radiology dropped by 11%. If I recall correctly, I didn't put it on the slide. I think that our lab tests fell by about 12 or 13%. Well, summarize just the cost side together, this waste elimination strategy through better care. We spent about $22 per member per year to deploy full team-based care, a level 3 accountable care organization. We saved about $115 per patient per year, per member per year, in terms of total medical expense, about a 5-to-1 return on investment. This is waste elimination. This is what it looks like in real clinical practice. I just wanted you to see it. You can find it in that JAMA article if you're really interested. It works, is the point. Lesson 3, most often better care is cheaper care. It's not always the case, but with waste being as high as it is today, huge opportunities. Now, this is arguably the most important slide I'll show you relative to our conversation today. We published it last summer in Harvard Business Review. I'm the lead author if you care to go track it down, but it's in Harvard Business Review, the July-August issue, talking about capitation. What I've done on the left is lay out 3 different classes of waste. Down at the bottom, we talk about efficiency. think of all care being made up of a whole bunch of little units of care, a single lab test, a single dose of a drug, a single imaging exam, a minute in a procedure room, an hour of acuity adjusted nursing care. Well, one of the things you could do to eliminate waste is to reduce your cost per unit. Get that dose of a drug for less money than you spent last year. Reduce the cost of the hip implant that you're doing, right? Reduce your cost of imaging so that the cost of a tube-view chest x-ray in your primary care clinic drops by 20%. That's an efficiency level, waste elimination improvement. Level 2, right above that, we call it within case utilization. Usually it's a physician with their pen writing orders, but I'll use 4 of that one, 1 of that one, 22 of that one, 15 of that one. And I'll grab units and pull them together into a case. See that idea? This is where the variation literature really applies when I find that different physicians use radically different approaches. It will be reflected in cost as well because of their choice of units. So variation falls under this. Oh, patient safety. Nearly always if you have a patient safety event, it means additional units of care get consumed. That's why the cost goes up when you have a patient injury in your care. This is where administrative inefficiencies fall as well. It's actually quite an extensive list. That's level 2, within case utilization. Level 3 is actually population health. We call it case rate utilization. Think of it as number of cases per population. So with team-based care, one of the things that happened is through better diabetes care for complex diabetics, so diabetes mellitus, at least 3 significant comorbid diseases, we reduced our 2-year hospitalization rate for those complex diabetic patients from 39% to 31%. So entire cases go away. They didn't need the hospital because their outpatient care anticipated likely consequences and prevented them in advance. Dramatic cost savings. Well, if I lay out waste in those 3 tiers, the second column in shows, at least when I personally model it, it shows of the total waste opportunity which fall in each category. Now, don't discount efficiency. It says only 5%. That's true. But last year for Intermountain, that was $20 million by improving efficiency. But it's just the smallest contributor in this crowd. The biggest is within case utilization, dealing with variation. That's about 50% of all waste opportunities. Very, very close, though, to population health, 45%. But the rest of the graph, the real point, it turns out that levels of waste interact with payment mechanisms. In the original article, we threw in cost plus. It was historically important. It really doesn't play a role anymore today. It's just there for academic interest. So throw out that left-hand column of red triangles pointing down. Fee-for-service payment, per case payment. I've called it on the slide provider at risk, and there are different levels of it. The pinnacle, the peak, is full capitation, where you both bear full financial risk. Now the point, it turns out that you have to make an investment to eliminate waste. If I'm at level 2, I have to drop in and somehow standardize care, and that takes real effort, real investment, real resources to make it happen. You're hoping to get some savings back through waste elimination to justify your investment. A red triangle pointing down means that you have to make the investment, but somebody else gets all the savings. It means the financial incentives don't align. The person who has to make the investment doesn't get the waste savings. I won't go into the details of working through them, but if you just think them through, they make perfect sense. Check out the article. It gives them in detail as well. Well, if I'm paid fee for service, the only real waste elimination that makes sense for me is efficiency enhancements, which has been true under a fee-for-service system. If I shift under DRGs, for example, per case payment, then I gain from within case utilization reduction by variation elimination, you see. But if I want to actually get the full benefit of waste in all its portions, I need to be in that right-hand column. I need to bear financial risk either through direct capitation or through some sort of a partnership. It has to do with aligning financial incentives. If you're paid fee for service and you start to try to improve your care to reduce the cost of care by waste elimination, it's kind of a paved road to financial destruction. You'll create windfall savings for purchasers, for insurers, for CMS, the government. While you suffer financially, you won't recoup enough money to pay for your investment in driving patient-focused change. That's the whole point. So this is really the case for capitation, either directly or indirectly using tools that I've described or others. You need to also think about how you financially align so that you harvest the benefit that you're generating. You see, lesson 4, yeah, these techniques require aligned financial incentives. You have to follow it all the way through. Now, a full program nearly always starts with key process analysis. That's where you identify the processes you want to start to manage. As you build them into clinical workflows, you'll get an aligned data system running. You'll get a series of registries that drive with it. You'll need then to get some sort of an operational structure to manage the care in your clinical services. So it's really a clinical management system. You will need to align financial incentives. I just wanted to show you one last little thing that makes it real. Some years ago, Intermountain CFO Bert Zimmerly made a key point. He said, you know, we're all over this quality thing, but without access to care, quality is meaningless. Accessible means affordable. If our services are not affordable, then our quality of care has no meaning to those who can't access their services in any case. He set a goal for the Intermountain system that we would limit our increases in rates to the community to consumer price index inflation plus 1%. This means we'll have bent the cost curve. He says I'm not supposed to say gross domestic product minus 2%. It means the cost of healthcare for the United States would grow more slowly than our national wealth. Well, we initially found that our expected growth curve, quite conservatively, was the line shown on this slide. Populations in this region of the United States are growing. We also have the baby boom in their chronic disease years, new technologies. This was a conservative estimate of what those additional services should impose as a burden on the community. If we were to limit ourselves to CPI plus 1, though, that's the line we had to hit. It meant by last year we needed to take 13% out of our cost of operations, $730 million. I have the data accurately through 2015. Through the end of 2015, we'd actually hit the 13% goal, taken out just under $690 million through the methods that I just described to you. What I'm really trying to say, by the way, this is in that Harvard Business Review article. It's what I'm really showing you. This stuff works, and it works very, very well. Frankly, that same year, we took some fairly significant hits with our entry into the ACA markets, had to do with risk order payments. Currently, the federal government owes us about $450 million that they haven't paid. The reason I think we were able to stand those hits and still do well financially is because of our improvement work with aligned financial incentives, where we were actively seeking risk within the populations we serve. This was our salvation, frankly, as it would be for any group who is trying to manage care to reduce costs through better outcomes and succeed financially through that approach. Oh, wait a minute, I just described an ACL, didn't I? The key is process management. Better clinical results produce lower costs, properly done. Now, more than half of all those cost savings will take the form of unused capacity. You'll free up clinic slots. You'll free up imaging use. You'll free up procedure slots. But it's going to be balanced by increasing demand. We know that demand for our services is going to continue to increase. That's my real message to you today. It's the idea that as professionals, we can greatly improve our care to our patients. And as administrators tightly tied in, we can turn that better patient care into financial survival. So with that, Tom, let me say thanks for your time and attention. We have a few minutes for questions from the group.
Yeah, and thank you everybody for, it actually turns out, I think the only sound coming, we've troubleshooted through the thing, is through my computer.
Oh, so that's why you put your computer
And that's why I put my
here.
computer by you. So thank you everyone for bearing with us. I didn't want to interrupt you, so this is a good break. So we're just huddled around my laptop here. Steve Jobs would be so happy because it's a Mac, and the audio is the only thing that seems to be working. We have like an ESPN setup here with headsets and everything, and just none of it's working. So thank you everyone for your feedback. We finished on this slide that better has no limits. Did you want to say anything about that?
Oh, it's just an old Yiddish proverb that's kind of my motto. I don't know how to do it perfectly.
Yeah.
You know, I'm very heavily engaged in patient safety for a very long time. I don't know how to make it perfect.
Yeah.
On the other hand, I do know how to make it better.
Yeah.
And I think that's our real objective, is to pass along something better than we ourselves received.
Yeah.
I think we've done that very, very well, and will continue to do so. Again, it measures out in the lives of the people we serve. It measures out in our professional commitments and the satisfaction, the meaning that we take from life. And frankly, it measures out in the financial stability of our organizations properly done.
Yeah.
So it brings the pieces together.
Yeah. Well, thank you for bringing all the pieces together for us and making the case for capitation and provider risk bearing. And so I have some questions, and I'll just remind everyone that you should be submitting your questions right now. And we will go to the queue in just a moment, but I'm going to take moderator's prerogative and ask a few of my own.
Okay.
Dr. James. And the first one is this, for you referenced the Harvard Business Review article several times, and what happened was our team in researching this subject came across that article, which I can't remember. I'm not sure how it happened on Harvard's end, but they had sort of a complimentary article, or maybe yours was a response to Michael Porter's case for bundled payments.
Yeah, that was Michael Porter and Bob Kaplan, and they were trying to set it up as a debate.
Yeah.
You know, one way of thinking about it, though, Tom, back when the Pioneer ACOs came out, there was a formal part of that coming out of CMMI where they kind of stacked up a series of steps. And what it did was move from fee-for-service medicine, pay for volume, and then over time, the idea is you step through these steps and you ended up at full capitation, pay for value. And they rate it this way and presented it this way. Well, the tippy top was full capitation, whereas a provider, you're bearing full financial risk on a per member per month basis of some sort, typically.
Yeah.
One step back was bundled payment.
Uh-huh.
Bundled payment is way high up the capitated payment arm. So, you know, capitated payment's not a pure concept. There are ways that you do it to different degrees along the way. And of the 7 levels, number 7 was full capitation, which we argued for. Number 6 was bundled payment. It makes sense for very tightly defined, strong boundaries, demarcated conditions, all right? Or for specialty groups is where it really makes sense, but it certainly doesn't cover all of medicine in most ACO groups. It's really hard to do bundles, for example, around chronic diseases because so many patients have multiple chronic diseases.
Yeah.
So we were making the argument, this came out through the articles, but it was a little bit of an artificial debate.
Yeah.
Because do you want capitation all the way or capitation heavy?
Right.
I mean, this wasn't even capitation light, like some of the MSSP 1 and 1 plus I think of as entree level capitation.
Right.
But then they build from there.
Uh-huh.
If that makes sense.
So they're not mutually exclusive. It
No.
it depends on your provider configuration. But in the end, you do that if you're an organization like Intermountain that wants to take care of basically every condition and every patient type in a given market, at that level, capitation is what makes ultimate financial sense.
When you start to integrate, and you will want to integrate, especially the finance piece with the care delivery piece, as you start to integrate, then you get to think of all of these things at once, at least internally. And I think that's probably where the world will continue to move in fits and starts, but it seems to be accelerating right now. But I think that's where we'll probably end up, is full integration.
Yeah.
And so we'll use all of these mechanisms along the way, you see. Now, interestingly, the underlying tool, that idea of shared baselines, it cuts across all of them.
Yeah.
It's foundational. It's just basic process science, Deming style. And that cuts across all of them, and it's becoming very common. Some people put different names on it, but that's the common theme that you see emerging. And by the way, it's not just us at Intermountain. I currently have about 50 sister training programs scattered around the world. Mm-hmm. The methods apply as well in Europe or in Canada or Australia or Singapore as they do here. And we're seeing, well, across the professions, the healing professions, we're seeing fairly rapid uptake of these new methods. The reason, it produces better patient outcomes. And that's what we're all about. Yeah. Is serving patients in their hour of need.
So, one of the sort of persistent questions in the delivery reform versus payment reform seems to be which one needs to happen first. From what I can tell, Intermountain sort of reformed the delivery first, and in other presentations you've made, you've shown where that has actually hurt Intermountain financially because
A little bit.
the payment model wasn't quite ready. So what do you recommend organizations do that are kind of in a place where they can't take full cap, for example, through their provider-owned health plan like Intermountain was able to, or don't have willing providers in their market? What do you do?
Well, an idea with this whole thing. Dr. Deming made the argument that you organize literally everything around value-added frontline work processes. It's a compelling argument, absolutely compelling. And of course, it transformed manufacturing around the world. The old joke was do Deming or die. And that sure turned out to be true. The way the work gets done at the front line forces you to think in terms of those clinical processes. So that's where you always should start, I would argue.
Okay.
You don't let the money drive the work. You let the work drive the money. You see? Maureen Bisignano at IHI called it light green dollars versus dark green. So huge waste opportunity. The way you actually take the waste out is by redesigning frontline work processes. So that takes the waste out. But you have to be able to follow through. You have to have that, hard right hook to follow up with your left jab, kind of.
Mm-hmm.
And that means administratively, you have to be able to turn that into financial benefit. Convert the light green dollars into dark green dollars.
Yeah.
And frankly, even though, sometimes we were hurt a little bit financially, we were pretty good at that. What it means is we had an administrative team that was backing up our clinical teams.
Yeah.
You see, but it takes that coordination between those. There's real integration between your clinical side that does the real work, that produces the real value, but then administratively you have to be able to follow up on it. If nothing else, you should be able to use it in contract negotiations under a fee-for-service contract.
Yeah.
Which we did fairly effectively, honestly, across probably 15 years was our main mechanism for doing it. Now, to the extent you're able, it just gives you the financial basis that you can start to move up the chain.
Mm-hmm.
And if you're competent to manage the care underneath, every step you take, you'll do better financially.
Yeah.
It'll actually drive you further and further up the ACO chain, you see. But the key is a coordination between the two halves, the two pieces.
Right.
So the initial clinical management piece, then feeding through into the administrative follow-through piece. At least that's how I think about it.
Yeah.
And by the way, there's some organizations who are doing this really well.
Yeah. Any names to name?
Well, I hesitate to say this. This is Kaiser's whole business model.
Yeah.
And they're growing fairly rapidly.
Yeah.
Watch out, guys. Watch out. Because there are people in the market who are moving on this.
Yeah.
You don't want to be number two to this game.
We are getting other questions. And so, Jacqueline, if you would maybe help me identify the organizations associated with these people. I'll ask one more question from my end, and then we'll go to the two that we have in the queue. So there was a lot of work, Dr. James, that went into some of the delivery reforms that you carried out at Intermountain. How does a smaller organization do that?
You're correct, Tom. It takes a certain size, especially to hammer out evidence-based best practice protocols and to curate them, to maintain them. It takes the backup data systems to go with it.
Yeah.
If you see what I mean. If I were a small organization, what I would do is I would understand my core work very clearly. So let's imagine I'm a primary care group.
Mm-hmm.
I would examine the primary care I deliver, and I'd be trying to identify a few key processes.
Yeah.
Maybe I have a really heavy service around type 2 diabetes mellitus. Maybe I have a disproportionate share in terms of depression, which is a common complication of many chronic diseases. But I'd try to understand my own work and the big clinical processes that define the work. I wouldn't try to boil the ocean. I'd try to pick off a few of those and then start to build around them. Now, it turns out it doesn't have to be perfect. Better has no limit.
Right.
You just have to come pretty close, and you just have to do better than the guys across town.
Yeah.
You just have to get that edge that carries you out an edge in front of them. That actually describes what I did for years.
Yeah.
We didn't do everything. We just had a few of them where I had an interested leader. Usually I could back them up with a little bit of data, usually on the fly, quick and dirty tally level data.
Mm-hmm.
then it would start to improve the care. That generated some more enthusiasm. We could then use that to kind of market to our patients a bit and get them engaged with it and interested in it, knowing that they're getting better care. You see the idea?
Yeah.
So you start small and you kind of build up. That's
Yeah.
what you do. And any good group, I think, can do it at a small scale. Now, something you need to know. Initially, Intermountain didn't invest in me that way. What we did was focus around the frontline care and then start to make the case.
Right.
And then build it up from there.
Yeah.
If that makes sense.
Yeah. Okay, great. Well, we're going to go to Barbara McKenney, who is from, speaking of specialty groups, Innovative Oncology Business Solutions. She has the question, how do you set the capitation rate so that you can manage the actuarial risk of having more very sick patients than expected?
Well, the first thing really heavily, you ought to be overinsuring.
Yeah.
So it turns out that that's a true insurance market. It's very, very efficient, but you ought to be out in the market buying overinsurance if you get outlier cases. And a big part of what you do is setting the dollar limit on a case for when you drop into the overinsurance market. Do you see what I mean? So you then take those unexpected, very high risk patients, right? And you share them with a broader group outside your own organization by reinsuring them. And frankly, you know, I'm leaving Intermountain, but still speaking for the system, very familiar with it. I think our current, I'll get this wrong, but I think our current limit is $5 million per case. And then we reinsure.
Yeah.
And what we're doing, a system the size of Intermountain, you know, that's got 1.5 million patients. We need to overinsure to reinsure. What you're doing is you're sharing those outlier patient risks across a much broader group through the reinsurance market.
Yeah.
So you better be thinking about that. Is what's my level for reinsurance? If I were a smaller organization, maybe I'd be setting it at 1 million or even 500,000, depending. Mm-hmm. Now, the other thing that you're thinking of in capitation, you need to take advantage of the knowledge in the insurance market in terms of how you market your services and how you attract patients, so that you get a fair, balanced risk across the populations you serve. This is a real common problem as clinicians. We're not very good at it, but there's a huge amount of experience. So if I were a small group, I would be buying services to actually measure actuarial risk. I'd be buying services to think about what we call benefit design, because if you design your benefits poorly, you're going to attract the wrong set of patients.
Yeah.
You see what I mean? I'd be thinking about where I do my marketing physically, in what media I try to attract patients. And then, this is a bad example, but it's an old joke. It was a for-profit insurance company who was trying to run a Medicare Advantage plan, and they held dances. Free community dances. And they were nearly always on the second or third story of a walk-up building. It's a joke. You see what they're doing?
Yeah. Yeah, they're screening.
I'm not suggesting you should be that unethical.
Yeah.
But you need to be thinking along those lines at least a little bit. What you're going for is a fair actuarial balance for the community that you serve.
Yeah.
And it's as much benefit design and marketing in terms of the patient populations you attract as just clinical process management.
Yeah.
So at least that's one set of ideas.
Yeah.
Probably some better ones out there.
All right. Well, I think our last question will go to Jerry Reeves from Health Insight, who asked, what will it take to spread the adoption of capitation in the U.S.? The
short answer is time. It's growing fairly rapidly, best I can tell. So, Denny Cortez was the CEO of Mayo, retired a few years ago when John Noseworthy took over. Denny's now down at Arizona State University in Phoenix. He's tracking the number of systems that are now owning insurance companies. Mm-hmm. If you own an insurance company, guys, you're capitated.
Right.
Welcome to the party.
Yeah.
He's up to about 60, and he claims that it's growing. That's a tough row, by the way. It's hard to do. On the other hand, I was talking to Lou Sandy. He's the chief medical officer at United. He made the most outrageous claim. He claims that he is currently the largest employer of primary care physicians in the United States. As a single employer. I've tried this on other people, and we all kind of, look skeptical. But on the other hand, Lou claims he's got the data. Why is it that United is buying up primary care practices? Now he's moved upstream in the flow, right? He wants to manage population health and take it out of the hospitals and the specialty groups.
Yeah.
Is what he's really setting up to do there. But what we see is this integration, where we're seeing the financing mechanisms integrate into the care delivery mechanisms from both sides. There's always a consolidator. But that's one of the things I watch as a leading indicator of where the market's going. And by the way, I check in with Levitt Partners all the time about where you see it too, because you have a pretty good finger on that pulse along the way. And what we're both seeing is that continues to grow, not just to grow, but to accelerate a bit.
Yeah.
That's capitated care, you see?
Yeah.
So by what marker? When I talked to Pat Conway, who's just stepping down as CMO at CMS, right? He claims that they're well ahead of their goals to shift into pay for value. And when he says pay for value, of course, it's not just upcoming APMs under MACRA, it's this whole push where providers carry more and more risks. So don't think that you have to be fully capitated. It's that chain in Pioneer ACO that chains you up a step at a time,
right,
as you grow toward it. And by any metric, everything I see is this is our future.
Yeah.
This isn't going away.
Yeah.
It's going to be more and more and more. So if you're in the ACO movement, you're an early adopter, you're getting the hard experience about how it really works.
Mm-hmm.
This is going to be essential to your long-term salvation. So well done, and a glorious future.
Yeah. Well, thank you, Dr. James. There you have it. We are so grateful that you guys stuck with us through the technical difficulties. That was just really great. We will ship out an audio recording and make this available, and that'll be included in our weekly summary that comes from Jacqueline. The next webinar will be October 11th, the week following our member meeting, October 4th, one more plug. And we'll be taking a closer look at some of the initiatives that will be announced at that member meeting. So a very exciting moment. And of course, if you have any questions about the ACLC or this webinar, please email members@accountablecarelc.org. We'll be happy to address your questions. Thanks for joining us. We hope you found this presentation worthwhile. Bye, everybody.
Bye now.